The next speaker is the president of the German Surgical Society, Professor Joachim Jene, and he will speak about peritonectomy and HIPEC, a glimmer of hope, carcinose péritonéale, peritonectomie et chimiohyperthermie, intrapéritonéale, lueur d'espoir. Please.
Esteemed audience, thank you very much for that invitation. My English is not as good as Hans Detlef Säger's, so merci beaucoup de votre invitation à cette rencontre, and that's about it. I had 2 years of French in school, but definitely not long enough to speak fluently during a presentation. As a president of the German Society, I can assure you that this meeting for our society is very important. We try to foster the German Society of Surgery for the future, and we try to establish a closer cooperation between other European and international surgical societies. So this is one step in our agenda, and I cordially invite you already right now for the next Congress in Munich, and the last slide will give you some details on that. Peritoneal carcinomatosis, why do I talk about that? You heard already Rudolf Pichelmeier, and I remember quite well back in 1994 when we operated on a patient with pseudomyxoma peritonei and limited disease, and he said to me, why don't you do the sugar maker procedure? And that's how it actually started. So I overlook now an experience of 20 years, and I think there is a glimmer of hope, and this talk will be optimistic as well as critical at both sides. Now, what will I talk about? I will give you a brief history of peritonectomy and HIPEC, the current indications for peritonectomy and HIPEC. I will talk a little bit about the scoring systems, the operative technique. I will give you perioperative data, in particular regarding morbidity and mortality, and then I will close with prognosis and a summary. Now in Germany, at least in Germany, there's a real surgical hype about peritonectomy and HIPEC. When I started with that in 1995, everybody called me crazy, and today you see here the centers that I know which do peritonectomy and HIPEC. It's about 40 centers, and they came up in the last, let's say, 10 to 15 years. And when you go to Google, and everybody Googles today, you see when you give peritonectomy and HIPEC more than 8,000 hits, and 6 months ago you had 500 hits less. And as I told you, in Germany, a lot of hospitals started with this treatment modality, although really hard data are still missing, and I tried to find out a little bit about peritonectomy and HIPEC here in France, and I found that homepage here, and I'm not sure if it's correct, but 26 centers in France perform peritonectomy and HIPEC, for example, Strasbourg, Dijon, Besançon, and so on. So all this happens, although hard and reliable data, especially of randomized trials, are still missing. So the question is all this really justified? As I told you, it started with this publication by Sugarbaker in 1987, when we reported about a case of malignant pseudomyxoma peritonei, and finally we had the Ronet classification for this particular disease and differentiated between the benign form and the malignant form, with substantial 5-year survival differences after peritonectomy and HIPEC. And when you look to that data here, you can see it hardly here. This is a survival analysis of pseudomyxoma peritonei patients, and you can see here that again the benign form has an excellent 10-year survival, and these are some examples of patients that we treated. The thing though is that all these data are promising, but they neglect the slow progression and the natural cause of untreated pseudomyxoma peritonei. I know patients for 10 years who never saw a surgeon, who never got treatment, that they are still alive. So long-term survival may be possible even without any kind of treatment. And there was just recently a nice editorial in the Journal of Clinical Oncology talking about xeromyxoma peritoneae, more questions than answers. Now, from xeromyxoma peritoneae to peritoneal carcinoma, the reason is simply that peritoneal carcinomatosis is a very common problem in colorectal cancer. At the initial time of diagnosis, about 15 to 20% of the patients have isolated peritoneal carcinomatosis, 20 to 30% together with other locations such as liver. Gastric cancer, about 10 to 20% at initial diagnosis, and ovarian cancer up to 80%. So this is the reason why so many oncologic surgeons started with peritonectomy and HIPEC in this kind of extensive tumor disease. And the current indications so far for peritonectomy and HIPEC are xeromyxoma peritoneae, peritoneal carcinomatosis of colon cancer, not rectal cancer, and there's weak evidence and a weak indication for peritonectomy and HIPEC in gastric cancer, ovarian cancer, sarcoma, and peritoneal mesothelioma. Definitely no indication is hepatopancreatic biliary malignancies. So when you have a patient with, for example, colon cancer, what are the selection criteria to offer this patient this very extensive multimodal treatment? In 2006, there was a consensus conference stating some selection criteria for the patient. So, for example, you need a very good ECOG performance status, no extra abdominal metastases, no stenosis at the common bile duct, and you need to apply scoring systems to stage the extent of disease as well as the quality of resections, which means can it be curative or will it be palliative? And all this is necessary to achieve a resection of all tumor nodules bigger than 2.5 millimeters, because only in these cases the patient may benefit from that. Now, the staging and classification systems that are currently available, the aims of these classifications are, first of all, a description of a tumor spread, second, determining resectability, determining the extent of resection, and they should also have a prognostic impact. And there are many, or basically 5 classification systems. One is quite old. It comes from the Japanese research for gastric cancer. It's a P classification. For peritoneal carcinomatosis, it's basically the Peritoneal Cancer Index, established in 1996, and the Simplified Peritoneal Cancer Score, established in 2003 by a Dutch group. And in almost all patients and almost all studies, it's the PCI, the Peritoneal Cancer Index, that is used. I won't go through all these various data. At the end of the day, the overall score may be as high as 39, and it was assumed that more than 20 points are a selective contraindication. The thing, though, is that it is a very subjective scoring, because it depends on the experience of the surgeon, how he classifies the peritoneal carcinomatosis, how he classifies the lesion size, and this is a major obstacle of this classification system. The same holds true for the completeness of cytoreduction score. That is the only available scoring system that is used to describe the extent of resection, and it differentiates between 4 scoring systems, goes up to 3, in describing what kind of tumor you leave behind. Now, basically it can be said, the lower the PCI, the higher the completeness of cytoreduction rate. This is a publication by Yoni Mura, just recently published, and it shows that if you have a so-called R0 resection, then you may have in colon cancer have long-term survivors. And here you can see it's colorectal cancer, appendiceal neoplasms, gastric cancer, and you can see that the best survival in appendiceal neoplasms, usually associated with a pseudomyxoma peritoneae and the worst in gastric cancer. In French, there's a very active group. It's Dominique Elias, it's Olivier Glien, and they did a multi-institutional study on 523 patients. And what they showed is, and this challenges the question, what is a contraindication for the resection? They showed quite surprising survival dates at 5 years, and what they show is that not only, as you remember, it was said 20 points in the PCI score is a contraindication for a resection, and what they found is that at 10 already, or even 6, that may be a contraindication. If a patient has 8 or 10 points in the PCI score, he's probably no longer a good candidate. I will further show you some more data on that. Now, an interim conclusion for all the scoring systems is that they may allow good classification of resectability, but they are all not validated, and most important, are influenced by the subjective impression and experience of the surgeon. And since all tumors, in particular colorectal cancer, are staged according to the TNM scheme, I wonder why we don't apply the R classification but try to establish other classification systems to categorize these tumors. And here you can see again, if you have a PCI of lower than 10, for example in colorectal cancer, you have excellent survival, and if it's higher than 10, you have a much lower survival. And these data again challenge the recommendations at which score on resection is worthwhile. I personally believe after 20 years that if a patient has 20 points in the PCI score, he is no longer a good candidate for peritonectomy and HIPEC. Now the own technique is, usually I go very briefly through that, is a median laparotomy, occasionally extended by subcostal right and left incisions, and then you need to do the complete digestive surgery, including urologic and gynecologic operations. It includes the parietal peritonectomy and the visceral peritonectomy, and it's usually associated with multi-visceral resections. And you need to, for example, do partial bladder resections. You need to do hysterectomy and en bloc resections together with a rectum. And it should be all done basically by 2 digestive surgeons. If you call the urologist and the gynecologist to this procedure, it will last even longer. Now the HIPEC, it's a closed system. And the temperature is 42 degrees Celsius, and we do it at 90 minutes. Some groups do it just for 30 minutes, other groups do it for 60 minutes. The question how long the chemotherapy should be done is still completely open. It's also open, should it be done open or closed? That question hasn't been answered. We use the open technique, and here you see some example. These are the catheters with the inflow, for measuring the temperature, and then it's all tied up to the retractor, and then it's covered so that there's no spillage. For colon, we use mitomycin C, and for other cisplatin, you also can use other drugs, and we call this the arena technique. And when you do the open technique, you can be sure that the chemotherapy goes in particular to the right subphrenic region. It never goes there when you do it in a closed fashion. Now this is just a short what kind of resections are necessary. You can see almost all patients require colorectal resections, almost all patients require omentectomy, cholecystectomy. It's sometimes very difficult to do the parietal peritonectomy at the diaphragm, so you sometimes need to do partial resection of the diaphragm, and as I said, you also have to do bladder operations and hysterectomies as well. The morbidity is here up to 50%. Overall mortality was 4.3%, but there's definitely a learning curve which goes much more down, and today you can expect a morbidity of about 3% for this procedure. I apologize for this busy slide. What it shows you is that the so-called grade 3-4 morbidity in this procedure is around 30%, and the mortality of this procedure is around 3 to 4%. Now this brings me to the question about morbidity. You all will agree that the definition of morbidity is mostly subjective, and in the literature, in particular regarding peritonectomy and HIPEC, many papers differentiate between minor and major complications, and most of the studies refer to grade 3 and grade 4 complications, so major complication requiring reoperation or ICU admission or interventional radiology or in-hospital mortality. And to be honest, the differentiation between minor and major complication appears to me as the attempt to reduce the real figures for the morbidity rates of peritonectomy. I hardly know a patient who does not have any kind of whatsoever complication. When you do an operation of 10 to 12 hours, and including peritonectomy, there's almost no patient who goes straight away out of the hospital. So all these numbers of 30% to me, try to look the data better than it really is. And infectious complications often related to bowel leakage are the most common causes of the morbidity. Nevertheless, this shows you some of these complications. Yeah? It's 65% with no complications, almost 60% here in colorectal cancer, 60% in appendiceal neoplasms, and even 75% no complications in peritonectomy for gastric cancer. I put a big question mark behind these data. But still, the question is this all justified with respect to survival and prognosis? And this paper just came out in the Journal of the American College of Surgeons, and it shows you in more than 1,000 patients and survival at 10 years of 20%. And when they differentiated for appendix, colon, mesothelium, gastric, not surprisingly, appendix is the best and gastric has the worst prognosis. What I think almost all data in the last 10 years showed that not only in the French study but also in the Dutch study in 2004, after 3 years there is a plateau for the survivors at about 20%. And I think it's most important to identify these patients who may most benefit from this procedure. And these data is 10 years old, and again, 10 years later, published this year, you have at 5 years and then with a plateau, survivors for a long period, and regarding all patients, you have a 5-year survival of 20% in a disease usually considered to be fatal. This paper also shows that a PCI of less than 10 has a much better prognosis than more than 10. Again, this probably needs or asks for a re-evaluation of the cutoff of 20 points of the PCI score. And patients with small bowel involvement should not be considered because they have such a poor prognosis. And this makes the number of patients who are really candidates for this kind of procedure really low. I told you that in Germany 30 to 40 hospitals started with that. The Dutch did it, at least to my impression, much better. Although they are much less inhabitants, they have just 6 hospitals doing this procedure. And in Amsterdam the group started first, and just recently in Nijmegen the hospital started with that procedure. So these were all trained by this group, and what they found here again is at 10 years In colorectal cancer patients with peritoneal carcinoma, a survival of 20%, and for pseudomyxoma peritoneal, not surprisingly, a survival of 60%. So all the data that you go through in the literature show that 20% survival in colon cancer patients with peritoneal carcinomatosis can be achieved by peritonectomy and HIPEC. And I told you that I'm critical. This is what in your country is recommended. Treatment is highly recommended for pseudomyxoma peritoneal, for peritoneal mesothelioma, for PCI of colorectal and gastric cancer. And in contrast, in Australia, the Australian government says there's insufficient evidence in relation to safety, effectiveness, and cost-effectiveness of peritonectomy and HIPEC for the treatment of patients with the rare disease of pseudomyxoma peritoneal or peritoneal mesothelioma. So Australians are much more reluctant. To my knowledge, there's just one group, that's a Morris group in Sydney. Great Britain, the NHS, that came out just in April this year, they consider it can be done, but just in experienced institutions, and in Great Britain there are only 2 institutions who do this procedure. And most interestingly, and that shows how many patients are really candidates for this procedure, are these data regarding the incidence and the overall numbers of patients, and then the number of patients with peritoneal carcinomatosis, fit for resections, the informed consent. And this is the amount of patients who may be candidates for peritonectomy and HIPEC. And when you look to that figure and this figure, you see that there's really a small amount of patients who are really candidates for this procedure. And it questions how many centers a country really needs. UK has 2, Netherlands just recently 6, France 26, and Germany over 40. And I think it doesn't make sense, to be honest. So in summary then, peritonectomy and HIPEC require a strict patient selection and a precise indication. Personally, for me, it's pseudomyxoma peritoneal and colon cancer, perhaps gastric cancer at an early stage of disease. There are no data if, for example, a T3 or T4 gastric carcinoma without peritoneal carcinomatosis should be treated with HIPEC as adjuvant treatment. Open questions are length of HIPEC, 30 versus 60 versus 90 minutes, open versus closed, the optimal temperature, and the optimal drug selection. I think the re-evaluation of the PCI regarding the cutoff for resection is necessary. Many data indicate a prognostic benefit. Selected patients may have a 5-year survival of 20%, and this is the glimmer of hope. The operative procedure requires substantial individual and institutional experience, should be usually done with 2 teams, changing every 2 to 3 hours or 4 hours. Perioperative results show a significant morbidity, may be as high as 100%, and due to advancements in systemic chemotherapy, comparative effectiveness studies are needed to precisely determine the value of peritonectomy and HIPEC. So this is the talk about peritonectomy and HIPEC. And finally, I spoke with my presidency ends in in exactly 19 days. And then Peter Vogt is the president for the year 2014-2015. On his behalf, I bring you as a present his invitation to the Congress, which will take place in Munich in May, beginning of May next year. Thank you very much for your attention. It was a pleasure to be here.
Thank you very much for this excellent and critical review of this difficult procedure. I would like to ask Philippe Lasserre to make a comment.
Congratulations for your presentation. In the Institut Gustave Roussy, we have an experience with peritonectomy and HIPEC. Dominique Elias has begun to use in the year 93, and currently close to 900 patients have been treated with this procedure. We estimate the very good indication is for malignant mesotheliomas. The 5-year survival rate of the 400 patients of multicentric registry was 47%. It's clear that pseudomyxoma and colorectal tumors are good indication. Concerning the benefits of HIPEC for gastric cancer, the 5-year survival rate of the 159 patients collected in French registry for the Association French Surgery report was only 13%. We think that actually HIPEC is not a standard for gastric cancer. It must be used with new modalities only on prospective trials. I would like to give 3 commentaries concerning the colorectal peritoneal carcinomatosis. Firstly, as Professor Yene has said, the PCI score is the main prognostic factor. On the PCI greater than 20, a contraindication to use HIPEC. The score used to select patients, reducing mortality and morbidity. Secondly, the peritoneal carcinomatosis must be treated at an early stage. The French surgeons are finishing to include 150 patients in the trial which randomizes the second look surgery plus HIPEC versus standard follow-up. In patients with a high risk to develop peritoneal carcinomatosis and high risk at the moment of the resection of the primary tumor, patients with few peritoneal nodule resect, patients with ovarian metastasis, and patients with perforated tumor. Finally, the French group has just finished to include 270 patients in a randomized trial comparing complete cytoreductive surgery plus systemic chemotherapy versus cytoreductive surgery plus HIPEC. This will show us that is the impact of surgery alone and that this impact of adding HIPEC. Conclusion, HIPEC is in progress.
Yeah, thank you for the comment. You said a very important sentence that hit early and hard. In Germany, many oncologists send the patient with peritoneal carcinomatosis after first line, second line, third line, fourth line, fifth line. And finally nothing can be done, and then, please surgeon, help me out. That is definitely not the wrong way, not the right way. So I think this approach to do a more aggressive approach to do early second look laparotomy, let's say after half a year or a year, to find out, okay, is there recurrence again, and then do it again. It's a wonderful approach. Thank you.
D'autres commentaires ou des questions? Si ce n'est pas le cas, merci beaucoup.